Good morning, Dr. Eckhert.
Good morning. Nice to be here. Thanks for asking me.
To start off, would you tell me where you went to medical school?
I went to the University of Buffalo Medical School, and then I did my training first at the Cleveland Clinic, and then I went to the University of Oklahoma because I got married while I was an intern, and my husband was in the Indian Health Service in Oklahoma, so I went to the University of Oklahoma. And when he finished the Indian Health Service, we went to Johns Hopkins, and I did got a master's of public health, and then became a clinical scholar and got a doctorate of public health. And then we came to Worcester. Came to Worcester in 1975, and I think we thought we were coming for about 5 years, and we've now been here 27, so it's been a very good time to be in Worcester. We came to Worcester because it was a brand new medical school, and we were interested in working at a medical school, and I came actually as a researcher in the department, which was then called Family and Community Medicine, and worked on a research project, and then became involved in medical school admissions. So I think I probably have a different career than a lot of other people that you may be interviewing. In admissions, it was a terrific job. Got to meet a lot of young people to encourage them to enter medicine as a profession. Went to many of the local colleges around Massachusetts and talked to the students, advised them on how to apply, what courses to take, how to be well-rounded as a person applying to medical school, what kinds of activities they should do on the outside. And sometimes help them with their applications, read their applications, or just gave advice on what would help their candidacy to medical school. I did that for about 8 years, and then I was chairman of the Department of Family and Community Medicine for about 15 years. And that was at a time when family medicine was really very much of a growing discipline. We went from a small interest in family medicine to 25% of the medical school class choosing family medicine as their career choice, something I'm very proud of. And what we see now is that many of the young physicians that are practicing in the Worcester community are people who graduated from our program, which has given access to a lot of primary care to people who would not have had that access. So that's been really excellent.
All right, well, what do you think got you into medicine? What made you decide to become a doctor?
Well, there's an interesting story. My father was a surgeon, and I remember very clearly, I was in grade 7, and I was sitting having lunch with my father and a friend of mine who was in grade 8, and the two of us told my dad that we thought we should go into medicine, 2 young girls. And he said, no, 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 women don't go into medicine, you shouldn't go into medicine. So, interesting enough, both of us are now physicians. Both of us took a little longer. I went and earned a Master of Nursing before I went into medical school. And she did other training and then went into medicine. But what was most interesting is after I got into medical school, my father was one of my greatest supporters. So I guess he then saw that medicine was really turning with more women going into it. Although it's really a little bit ahead of that curve. Now we have about half of the medical students are women, and when I went to medical school, there were less than 10% were women in my class.
So what made you decide to keep being a doctor when you started practicing medicine? What did you like about your practice?
Well, I had a wonderful career, and part of it has been that there's been a great variety in what I've been able to do. I had a practice at UMass Medical School for 27 years, taking care of children. I had a small practice, and I think it was a very devoted group of patients who were families that were quite independent. They were families that were kind enough to see me through some of my own career changes. I took 1 year off to live in Africa to teach at a medical school. My husband, who's a pediatrician, and I took our 3 children there, and they stayed with me during that period. So it's been the variety, the fact that I had the opportunity of being Dean of Admissions in the medical school, the opportunity to be chairman of the Department of Family and Community Medicine, and most recently I had a very interesting experience as the acting chairman of radiology at UMass Medical School, filling in during an interim period that was a bit tumultuous, but worked out, and they now have a new permanent chairman, and I'm sure things will move forward and be very successful.
Okay, well, before I move on to talk about your career more, is there anything else you'd like to share about your experience in medical school or during your residency or internship? Any other stories or anything you want to talk about?
Since I teach medical students now, it's been fascinating to see the changes that have happened just by seeing the number of women increase so much. Going from a handful of people in a medical school class to half of the class being women, I think has really changed how we were viewed, how comfortable the students are with each other and with being more assertive and really having their opinions known. It was much harder when you were one of very few. You were often the only woman in a seminar. Something that was perpetuated throughout my career. I was the only woman chairman of a medical school department the whole time that I was there. And I think that leadership in medicine needs more women, and we're beginning to see more women who are department chairs, deans of medical schools, CEOs of hospitals. So that's been a major change I've seen.
How much did it cost for you to go to medical school?
Well, it's very interesting. We had 4 years of undergraduate college. I went to a private college, so that was the more expensive part, because when I went to medical school in Buffalo, it was less than, if I remember correctly, it was less than $1,000 a year per year. And I also had a New York State Regents scholarship, which paid part of my tuition. So I certainly have paid more for my children to go to nursery school per year than it costs to go to medical school for me. I also lived at home, which made a big difference than if I had an apartment and those kinds of things.
Do you think that the increased med school costs today influence the choices of young doctors after they graduate med school compared to when you went to med school?
I still think that most students make their choices on what they love to do best. I think they're getting good advice from faculty and from community physicians, basically from all physicians, that if you do what you love, you will do well at it. All physicians have a much better income than most other people. So I suppose there are some people who are making their decision totally monetarily, but I think that's probably a very small number, very small number. I think people are doing what they love to do in medicine, and that's how they make their career choice.
All right, well, when you started practicing in Worcester, could you describe a typical day from when you started practicing in Worcester?
Well, when I started practicing in Worcester, it's really fascinating because I came to the medical school to do research, and I came when the hospital was not even finished. It was 1975. We used to be able to park right next to the medical school in a muddy parking lot, and we weren't paying for parking, and we could be 50 feet from the door. The hospital then opened in 1976, and we then started seeing patients in the ambulatory care setting. So We saw some of the very first patients that came here. In fact, one of my children that I took care of was the first child that was ever in the intensive care unit at UMass, and it was actually an adult unit. And that child, I have taken care of her children too in the later on. So it's been that nice continuity that has really made a difference. But certainly there was a lot of very good medicine being practiced in Worcester prior to the medical school coming. I just was not here at that time, but I was able to get to know some of the pediatricians, Bob Cox, Jane Fitzpatrick, Arnie Gerwitz, just some of the pediatricians that were in town. And they became very committed to the teaching programs of medical students and residents and things that were happening in the community. They had been doing that before, and they wanted to make sure that the next generation had similar opportunities that they had had. So I think that was extraordinarily helpful. What's been a big change is the number of hospitals that have closed since I first came. City Hospital is now an ambulatory care center. St. Vincent's is no longer an acute care hospital in the same location, is now downtown with Medical City. Fairlawn Hospital closed. You know, we can make a long list. So those have been some of the changes. I was always practicing as well as doing either research or administration. So I think my practice is different than a lot of people. And I was very fortunate in really being able to have a very closeness with many of my patients.
So what were your hours like in a typical day?
It's interesting. I've always liked to work. So we used to start at the medical school. Mostly I started around 8. And often we had meetings in the evening too. I mean, so had long hours. Sometimes I would be home, you know, at 6, and sometimes I would be home at 8. I also took night call at that time. So would come into the hospital and see patients, would come to the emergency room to see patients. It just seemed like the way you practiced. I mean, I had grown up in a physician's family, and my father wasn't home all that much. I certainly have been home much more than he has. I also am married to a physician who is so we just had this basic understanding of what life would be like as a physician couple, and it worked out extraordinarily well. Just worked out.
Did you use the telephone often to talk with your patients?
Yes, in pediatrics we use the telephone a lot to talk to patients. Some of it is trying to help them with an actual illness that they have at the time. A lot of it is reassurance. A lot of it is just discussing the changes in their children, growth and development patterns. What I have seen is so many of our young parents do not live around their own parents, so that the grandparents are not nearby. And some of the questions I think that previously they would have asked their mother or their mother-in-law, they're now asking their physician and getting more of a professional viewpoint on it. I think having been a parent made it easier to partner with the parents of my patients in helping them raise their children. It's a very special privilege to be able to do that, to partner with parents and help them.
Did you ever make a house call?
Oh yes, I did. It's not something that I did a lot of, but it was something that sometimes I even had patients come to my house if they lived nearby, or I went to their homes depending on the situation with the child. It's a good way to understand the environment in which a child is growing up in and the things that a parent has to cope with. So, yes, one of my favorite stories is actually a child that had an intussusception that initially the X-ray was read without an intussusception, and then a pediatric radiologist read it, and the two of us tried to get a hold of the family to get the family, bring the child back who had been sent home, and they didn't have a phone. So we ended up, the two of us went out one evening and drove around to the streets in Worcester finding this child and getting him back in, and that was sort of a fun thing to do, and had him treated and things went well.
So did most of your patients live around the Worcester area?
Yes, most of my patients are, I don't know if I'd say just Worcester, but Central Mass. There are a lot of them from, Spencer and Leominster and Grafton, and so it was around Central Mass.
Did patients, or did their parents have the opportunity to choose their physician?
Yes, they did. What we have seen is when health plans, particularly HMOs, came in, there was a lot of sort of shifting around, and that until the physicians were on a lot of panels, there was more shifting, I think. But then once when we were on a lot of panels that the patients could have one insurance or another, they could still see the same physician. I think it made it much easier. But in the beginning of managed care, I remember losing patients who were going to be on a plan that we were not, that the medical school wasn't a member of, and then may become a member later. Or so the patients sometimes, I had patients that shifted from my practice out and then back in again. That happened a number of times. But more recently, I haven't seen that as such an issue. I certainly wish that we had some sort of a universal health insurance plan that allowed people to keep whichever physicians they had that they would like. I think it would be helpful for the patients, the families, and the physicians too, but mostly for the families. It would have made better sense.
What do you think it was like for your family to have a physician in their household, or two physicians actually, because your husband
Yeah.
was one household?
I guess it's just sort of been a way of life for us. First place, both my husband and I, our fathers were physicians, so this is what we grew up with. My husband's grandfather was a physician, so his father grew up with that. So it's sort of been a way of life. And our children, I think it's all they ever knew. And I think they were very proud of what we did. We tried to include them. We sometimes took them on rounds. We took them to work in the Indian Health Service with us. My husband had been in the Indian Health Service in the 70s, and he reactivated periodically because that was something that the Indian Health Service asked him to do. And so we took the children to Shiprock for a month one summer, and then we went to Gallup and took one of our children to Gallup. We took them to Haiti when we worked in a mission hospital, relieving one of the physicians who had been in training with us, a Dr. James, lived in Haiti, and they needed some extra help. And so we took the children, and they became very involved in feeding some orphan children who were orphaned because of HIV, and working with the pharmacy in getting rid of unused drugs that had expired or that were not very useful in Haiti. And then we took them to Africa for a year. So I think medicine has been very inspiring for them to see the variety of things that you could do in medicine. Their dad is a pediatrician, but before that he was head of the pediatric emergency room at St. Vincent Hospital. And sometimes they would go over there and have dinner with him. We would go over there to so we were trying to include them in our lives so they knew what we were doing. And I think they took away a real value from that.
Moving back to your practice now, what were the most typical illnesses that you treated when you started practicing pediatrics?
Probably the most interesting thing that has happened in pediatrics happened from the time I was a resident until early practice, actually, and has continued. When I was a resident, we treated a lot of patients with meningitis, epiglottitis. Subsequently, there's been a Haemophilus influenza B vaccine, which has made an incredible difference in the outcome for children. Meningitis is a relatively rare disease now. Certainly, H. flu meningitis is basically unheard of, as is epiglottitis. And so some of the emergencies that occurred during those times are gone. Now, the people that practiced ahead of me, I know, talking to Jane Fitzpatrick, when she talks about taking care of people with polio, children with polio, this was something that I never experienced. Certainly I never experienced in the United States. I've experienced some of these infectious diseases by practicing overseas, particularly in Africa, where we saw many cases of measles and many complications from measles. And here in Worcester, there was a child with a case of measles several years ago who was a young child who had been visiting in Asia and was under a year and had not, as he should not, would not have been necessary, been vaccinated against measles and contracted measles while he was in Asia, but the rash and the symptoms showed up when he came back to the United States. And what I found interesting is I was asked, as well as the infectious disease people, to see this child because many of the pediatricians had never seen measles. I had seen measles because I had been overseas. Some of the older pediatricians had seen measles because it was around much more commonly. So some of those things have changed. We've gotten much more involved in a lot of the behavioral issues and the school issues and much more chronic illnesses in children than I spent my time in my training. So I think that's been the biggest change.
What was the greatest challenge for you to treat when you started practicing?
I want to go back to when I was a resident, because when I was a resident, I spent, when I was a medical student, I had gone to Africa and worked in Liberia. And in Liberia, I saw a lot of tetanus, and we particularly saw it in newborns when they were, the child was delivered and the cord was cut with a instrument that wasn't clean, and the child contracted tetanus and became symptomatic around 6 days of age. When I was a resident at the University of Oklahoma for 1 year, I had a 3-year-old child who came in with the symptoms of tetanus, and it turned out that he had stepped on a belt buckle on a farm and had not been fully immunized, and he had tetanus. He was probably the most interesting case that I saw during my residency. Many complications, but to think that here an entirely preventable disease was actually occurring right in the United States was sort of extraordinary. So he's one of the outstanding cases I remember.
And how about now, what do you think is most challenging to treat in your field? Obviously, tetanus is not a problem anymore.
You know, I think that our society is much more complicated now. And I think just if you take, you can look at some of the really difficult medical problems or the malignancies and stuff that children have, although we've seen extraordinary success. We look at childhood acute lymphocytic leukemia, and 90% of those children are surviving now and doing very well compared to, you know, either when I was a child or even when I was a resident. We certainly didn't see the success that we see now. But we see a lot of asthma, and some of the chronic diseases. But I also think that the complicated society has made it harder for parents to raise their children. The fact that the families are scattered around the United States or are scattered around various other countries means that many people are really isolated. And I think that the families are looking for guidance from professionals to help them in the raising of their children, help them deal with just the day-to-day behavioral issues that come up, dealing with the school system, helping children reach their full potential, keeping them away from some of the diseases that are causing the biggest morbidity now. If you look at it, it's accidents, mental health issues, anorexia. Those problems are very complicated and require a team of professionals, and I think that's one of the biggest changes that we've seen. The other area that's extraordinarily exciting, of course, is the genetics, and some of the ability to determine what problems are inherited, and what preventive measures families can work on to prevent some of the future illnesses is very exciting.
It's a growing field.
Yes, absolutely.
What do you think was one of the most important breakthroughs in disease treatment throughout the course of your career?
I would have to say, because I'm a pediatrician, I would have to say some of the newer immunizations, particularly Haemophilus influenza. Now we have a pneumococcal vaccine. We've had a little problem with the some of the vaccines, but the vaccines have really made a biggest difference, I'd say.
Could you briefly describe attitudes towards smoking and cancer generally throughout your career?
Well, even in medical school, in the late 60s, we were talking about the relationship between smoking and lung cancer. But we didn't have the same activism against smoking at that time that we've had in the last, say, 20 years. And one of the faculty in the Department of Family Medicine, Dr. Joe DeFranza, has done a lot of work. And it was nice to be able to be associated with him and to hear him talk about what he was trying to accomplish and how he was really working on preventing children from smoking, since it is the young people that become addicted at young teen years. So I think the acceptance by society that smoking did cause harm to your health, not only cancer, but heart disease, in the relationship to smoking, obesity, hypertension, all of those things together, diabetes, really has been an extraordinary breakthrough, and it's delightful to be able to go to restaurants which are non-smoking now, and to go to public buildings which are non-smoking now, and to think back 25 years ago how different that was, and how you rode on airplanes and there was a smoking section in the back, and just to see that there's been some real activism around that issue is terrific.
You probably even saw a lot of doctors smoking.
I didn't see a lot of doctors smoking, but I certainly saw some. I did see some. It was always interesting when it was your pulmonary professor, who I had one in medical school, that smoked. I mean, that it helped you understand the fact that it is an addiction and that it is not easy to give up. And it helped me understand in working with families. And that this wasn't something that you could just rationally say, well, I'm going to give this up, it's just going to happen, because it didn't. It didn't. But it made it even more important that we work to help children not start smoking.
In terms of technology, what is something that you think doctors seem to take for granted now that you didn't have during your career?
Oh, the whole imaging
Yeah.
area is just extraordinary. The differences with MRIs and CT scans and some of the procedures that the radiologists can do now. And others can also do laparoscopy that just weren't anything that we were exposed to, that I was exposed to in medical school. And I think they've made such a difference in being able to make a quicker diagnosis, an accurate diagnosis, and safer for the patient.
What did you have in terms of technology? What did you use to make diagnoses when you started practicing, when the imaging stuff didn't exist?
Well, when I started, the imaging kind of studies we had were plain, what we call plain films in radiology, and fluoroscopy. There was a little bit of ultrasound was developing at that time, if I remember correctly. A lot of barium enemas and barium swallows and those kinds of things. But the change has been immense. One thing that I think is very interesting, though, is that the lab work, and I'm talking in terms of blood work, as a medical student, we used to do a lot of our own lab work. Now, a lot of people say, well, that's really scut, but I remember doing spinal taps and looking at the CSF ourselves and doing the cell counts and doing stains for bacteria, and what an extraordinary learning experience that was. We just didn't sort of count on the lab. And reviewing a smear, for example, of a blood smear of a patient with a pathologist was a wonderful learning experience for me as a student and as a resident. And it sort of expanded how we thought about things. And I think the students and the residents are less involved with those lab kind of studies now. And, you know, that's just one of the changes in medicine. The techniques are better and they can get quicker answers other ways. So.
Did you have access to the new technology in your field?
Oh, yes, certainly, because you know, currently I can get any of the imaging studies. The specialization of radiology has resulted in certain people just doing pediatric radiology, and you just count on them to be up to date on the newest techniques, and that they will, it has to be a partnership, so you have to, it's best, I think, to talk to either the lab people or the radiology people or the specialists to talk about, okay, this is what the symptoms of such and such a patient are, and these are the signs. What do you think are the best ways that we could go after specific diagnoses? So there's much more, I think, of a partnership in medicine, teams, than we used to have. And I think that's to the benefit of the patient. It may also make it much more complicated for the patient because they have many more physicians that they're dealing with, and they're not always quite sure who's doing what and who's in charge and those kind of things. I think we still have a ways to go in coordinating some of that care.
Is there anything that you would like to see invented in medical technology or even disease treatment in the near future?
Oh, sure. There are lots of things that would be wonderful to see, particularly around the chronic diseases. Sort of combining genetics and prevention are the areas that I'd be particularly interested in seeing. And I think with the Genome Project, we should see some real breakthroughs. You know, like now you can identify certain women who are at high risk of breast cancer, and you can make changes in their management. when they get mammographies, at what age they start, how often, those kinds of things. I'd like to see more breakthroughs, and I think we're seeing some right now in treatment of diabetes and genetic, new genetic capabilities so that insulin never would be needed. And some of these things are, being worked on now. So being diced in pediatrics to have improvements in prevention of cystic fibrosis and better asthma treatment, although the asthma treatment is very different from when I was a resident and much improved, and children are able to lead much better lives. It's just that the prevalence of the disease is much greater than it used to be.
So what were some of the most important drugs in your practice, and how have they evolved over the years?
That's an interesting question, because I think most pediatricians would say that clearly it's vaccines that have made the difference, and the other thing that we use a lot of are antibiotics. And probably what's happened most recently is the concern, and the particularly concern by public health agencies and CDC, for example, and the overuse of antibiotics in guiding professionals, physicians, nurses, nurse practitioners, and families in saying, I don't need an antibiotic for this illness, that it's better to let it run its course, that it's a viral illness, it's not going to respond to antibiotics anyway, that we have overused antibiotics. So here, on the one hand, I'm saying antibiotics made a big difference in pediatrics, and on the other, I'm saying, well, we probably went a little too far. And I'm not just in pediatrics, but sort of across the board in family medicine and in internal medicine in adults, that we should be more judicious in our use of antibiotics. The other big change in the use of medications has been in the asthma field, which I mentioned, and also in mental health, and the ability to really treat patients with mental health problems, depression, obsessive compulsive disorder, patients who are psychotic, to be able to manage them on an ambulatory basis, I think has made a big difference to the patients themselves, and also to their families and to the communities in which they live.
Did you always have access to the drugs you wanted to use?
You have to remember that I practiced in Africa part of the time, and so no, I did not always have access. But in the United States, I would say yes. But it was a fascinating experience. In Africa, I practiced in Zimbabwe, and they had what was called an essential drug list. And what it is, it's a listing of the drugs that the country can afford, and by class. And so at an ambulatory care center, there would be a small number of drugs that are used. There'd be some antibiotics and some cardiovascular medicines, but there probably would be no medicines for cancer therapy, for example. Then at the next level, which would be a provincial hospital, there would be certain medications. And then at the tertiary care hospitals, of which there's probably only one or two, in Zimbabwe there were only one or two in the country, the most sophisticated drugs were used. So unless you were practicing in that environment of the tertiary care hospital, you would not have access to all drugs. What's been fascinating to see is the change with managed care in the United States and the development of formularies, which in many ways are essential drug lists. They're just broader, but they have become somewhat more restrictive in their use of drugs, of who can use drugs. Certain drugs like Accutane is used primarily by dermatologists, and most primary care physicians are not using that drug. And there's been some questioning of drugs by managed care that I have not found very helpful. But for the most part, I would say the pharmaceuticals I want to use, I could use.
Okay, well, I'm going to medicines and technology now.
Okay.
Okay. Well, do you think? Well, how did patients without money receive health care when you started practicing?
When I started practicing, I think many of us, and certainly my predecessors, saw many, many more patients just on a pro bono basis. Patient came and they just cared for them. There were also institutions, particularly, for example, the city hospital would have probably seen a disproportionate number of people who were not paying patients. It's changed over time. We still have a very high number of people who are poorly insured or not insured at all, although there's been a great assistance for children in having children receiving some universal coverage. Families that are not eligible for Medicaid, for example, can get coverage for their children. Still, the whole issue of universal health insurance is an important issue to me that I would like to see health care as is a right, and everybody should be able to get it.
In your practice, how have you seen managed care with Medicare and Medicaid and HMOs affect physicians, patients, and generally people's access to health care?
You know, I'm probably not one of the best people to answer that question because as a pediatrician, I don't really have much to do with Medicare. There's certainly, but my experience with working with family physicians and my experience with colleagues, there's certainly been a great deal of concern in the ability for people to access care is still an issue. And for the near future, it looks like it will continue to be so.
Well, do you have any further opinions that you'd like to express on HMOs or managed care?
No, I really don't. I think that the physicians in the community have a much better understanding and about these issues than I do, than I would want to express.
So your practice wasn't particularly affected by HMOs or managed care?
No, I think everybody's was affected by it, but you have to remember that my actually seeing patients was much smaller proportion of what I spent my time doing than most physicians. I was doing administrative things, and I also was doing a lot of international health. Was running a center at UMass Medical School for International Health, and so I was helping students design projects and go overseas, but mostly I was working with other professionals from overseas. I brought 25 Egyptian physicians to the United States to learn about primary care. Now, not about primary care clinically, but about primary care systems, record-keeping systems, working with teams of nurses, working with other ambulatory services for them to get an idea of what was being done in the United States. And each of those physicians designed a project, and then I went back to Egypt on several occasions and to see what had been done. So my practice, clinical practice, was relatively small, and the administrative things that I did was much larger. So.
How have doctors' salaries changed over the course of your practice?
You know, as chairman of a department, that was fascinating to see because I'd say in the mid-90s, primary care became very extraordinarily important. Now that happened partly because managed care decided at that time that if they used more primary care physicians, and the term they used, which isn't a very nice term, I don't think, is gatekeeper, that by using the primary care physicians, they might use specialists less. I think this has changed over time. But anyway, at that time, when I was busy trying to hire, help UMass set up a network of primary care physicians, everyone was trying to do this, and the salaries for primary care physicians really went up considerably, to the point where it was very difficult for us to recruit young new graduates in primary care because there was so much competition at that time, so that the salaries really were a lot higher than certainly what I started with. Then, in the last few months while I was running radiology, there's a national shortage of radiologists, and so that there was now a real competition and sort of bidding war for radiologists. So I think part of this is cyclic. I think that physician salaries, if we depend on who we're comparing them to. If we compare them to physicians around the world, their salaries in the United States are extraordinary. There are always complaints. People say they don't, make enough. I think that we make a very good living as physicians, and so this is not an area that I worry about. But it's been somewhat cyclic depending on where there's a shortage. So when there's considered a shortage of primary care physicians, those salaries go up, and then when radiology, those go up, and anesthesia would be another one that probably is on its salaries go up, and then somebody else's may go down, and then when that becomes a shortage. So it's a supply and demand.
How has malpractice insurance and its impact on the medical practice changed over the years?
It's fascinating talking about malpractice with some people from various states, not just Massachusetts. I'm most familiar with the medical school making a decision to have a self-insurance trust when the rates were skyrocketing, and I think it was in the mid to late 70s, if I'm correct, when it was a decision that we should form our own group, which happens to be done at quite a number of major institutions, particularly medical schools do that. But recently I was talking to physicians from Florida who have told me that their rates are just absolutely skyrocketing, and some of them are even going bare, which means they're not carrying any malpractice, which I think is a clear problem for them. Does it make a difference to how we practice? I think it does. I'd like to think that we all practice the best medicine all the time, but I also know that there's some defensive practice of medicine, particularly if you're in a setting where you don't know the patient beforehand or you don't know the family, and you want to really be safe for the patient and for yourself. The Chester ordered that probably if you knew the patient better, had a long-term relationship with them, you might wait and say, let's see how the progression of the illness occurs. But there's more pressure to get the answer yesterday than there used to be.
How did you end up learning the business of medicine?
The way I look at the business of medicine is probably different than a private practitioner in the community, because they would have a smaller practice. I had to learn the complexities of running a department, which meant I had to look at various sources of income, grants, state funds, contracts, as well as clinical medicine. And I think you'll learn that by working with really good people who are doing it, business people. And I also took a couple courses. I took 2 courses at Harvard for clinical chairs, where I actually learned about much more about budgets and about management and sort of making bottom line and maximizing your resources, yeah, with efficiency, greater efficiency. So I think those courses at Harvard were very, very helpful.
What are some changes that you've seen in the demographics of the Worcester community?
I think in the Worcester community we're seeing some ethnic changes with a larger Latino population than we've seen in the past, but we're also seeing many more elderly people. And we're seeing some changes economically, particularly recently, which are making it harder for people to make ends meet, to just live the kind of lives that they wanted to see. So I would say the biggest things are a growth in young immigrant populations and a graying of the people living in Worcester, and a change in the economics, like probably everywhere else right now.
How has women's health in Worcester changed over the course of your practice?
Now I don't take care of women because I take care of children, but there are many more people that are just interested in it. There's a consortium of people who are trying to developing a curriculum for women's health in medicine, for example. There's just a greater acknowledgement that women are asking for certain services, so that some of the hospitals have developed women's services, mammography, for example, mammography screening, for example. So in 27 years, when you didn't really think much about women separately, except for obstetric services, much more is going on. Women's health initiative that's occurring. Those are very positive changes. Women in medicine, I think, are very positive. There are a lot of women that call me that are looking for a woman physician and are asking who I would recommend. And I don't always recommend that it's a woman, because some of the, I mean, clearly men are interested in women's health care and are very proficient. So it doesn't mean that it has to be a woman.
And what changes have you seen in how children are cared for? Your field, obviously. Have you seen that change?
Yeah, I think many pediatricians are really working on really respecting children for who they are and listening to them much more carefully. What are their needs? What are their expectations? For example, if you look at some of the adolescents, having school health programs is a real difference that we'd never seen before. Just having young people involved in their own health care. They can make very reasonable choices, and they can really assist us in designing programs. I think it's very helpful.
Would you care to comment further on your international practice in Haiti and in Africa?
That's really been a highlight of my life, and I think the life of my husband definitely, and our family. We have been very fortunate in the gifts that we have been given as physicians and as a family, and I think we've found it extraordinarily rewarding to work overseas. Right now, I'm involved with the Educational Commission for Foreign Medical Graduates, and one of the things that I find most exciting is that we've developed programs where we're developing educational programs for faculty from overseas, so that they can come to the United States, learn some specific skills, in educational skills in medical education, and that they can go back and transfer those to the young people from around the world, so that it's a real growth experience, and it's a multiplier effect. So I can teach medical students in the United States, but I can also teach or help faculty get into programs that are sponsored by ECFMG that will really have a major impact on areas of the world that don't have enough physicians. And that's very exciting, very exciting.
Have you ever practiced anywhere else inside the United States?
No, no. After I finished the Clinical Scholars Program in Baltimore, I came right to Worcester. And here I am, still here.
Why exactly did you choose to practice in Worcester throughout most of your career?
Well, you know, we originally came, I think I said, for about 5 years. We thought this was a brand new medical school. It was a bigger risk to take. And it was a good thing to do as a young person. It turned out that it was a very exciting community, very vibrant, and at the time it just seemed like the right place to be. And then many, many new opportunities have opened up over the years, and we've put our roots down here, and it's been very positive.
How do you feel the role of the physician in this community has changed over the years?
Well, certainly the number of physicians in this community have expanded tremendously. But because the number of hospitals has declined, we're practicing in much bigger groups. Sometimes I think there's a real impersonal quality to that, which I think is not to the advantage of either the physician or probably to the patient. But there's some real advantages also, probably in terms of cost, in terms of availability of more expensive procedures and technology that small hospitals probably couldn't afford. I think that's probably a key point.
Were there Worcester physicians that you admired when you started practicing here?
Yes. Probably the key person is Jane Fitzpatrick. Dr. Fitzpatrick is a pediatrician for years and years, very well known in the community, very well respected by her patients, and she continues to give to the community, volunteering her time. She's a model for community service, and she's still doing an immunization clinic for the Department of Public Health, and for that we're really proud. Another person has been Dr. Leonard Morris, and he's an iconoclastic physician who sets a very high ethical and moral standard for his profession, which the rest of us try to live up to. And he's been involved in the medical society, both at the district level, the state level, and now at the national level. More recently in the ethical arena at the national level. And I think he believes that physicians have a code of ethics that we need to live by and need to communicate to the public that we are putting them first and medicine first before our own special needs. And I think that's something all of us should honor.
Okay, well, before we wrap up here, Dr. Eckhert, would you like to briefly comment on changes in medical education, or comment on your role as an administrator at UMass?
Okay.
Further?
Sure. One of the things that's been interesting in medical education is to see what's happening to medical students. For the last 5 years, we've had a decline in the number of people applying across the board, across the nation in medicine. I'm hoping that that's just temporary. I'm hoping that it's cyclic like it has been in the past. But we still have very honorable, bright, energetic, innovative young people who are wonderful to teach. I've just thoroughly enjoyed working with the medical students. I've been fortunate to, in the last 3 years, to have a first-year seminar with medical students, to see their eagerness, to see them wrestle with the important ethical and moral decisions of medicine at young ages is very exciting. So I think there's still a very bright future for medicine, and any young person that asks me, should they become a doctor, it's very easy to say with a resounding yes.
All right, well, obviously, medicine is a growing and changing field and will always continue to be so. But how have you seen yourself keeping up with the changes in medicine in terms of education after you were all finished with medical school throughout your practice?
Okay. It is a responsibility of the discipline of medicine to keep up, and it's a responsibility of the discipline to teach the next generation of physicians. And in order to do that, one must participate in lectures, take courses, communicate with other professionals. Since I'm in medical education, I work a lot with the Association of American Medical Colleges, and they are a marvelous institution for keeping one updated on the most current changes that affect medical education. So through the newest methods of communication, listservs and web use, you can keep up, I think, a little better than you could. You can sign up for various web services like pediatric alerts and.
Sorry, Doctor, I have to cut you off.
Okay.
Because we're almost out of time.
Okay.
Lastly, what advice do you have for younger doctors?
My advice for younger doctors is enjoy it. It's a marvelous profession. The opportunities are endless.